All right. Well, hello, everyone, and thank you so much for joining us today. My name is Ivania Covington, and I am the new Community Partnership Coordinator for Faith-Based Partnerships and Senior Strategies in the Social Responsibility Department here at Baptist Health. So this is our first Community Health Education Series for 2022, and this month our topic is Dementia and Cognition. So we have two speakers who have so graciously accepted our invitation to present tonight, and I will be introducing them in just a moment. But first, we usually begin our sessions with prayer. So I would like to ask my colleague, Mr. Paul Cook, if he would lead us. Then, following prayer, I will be reviewing a few housekeeping items, and we will have the presentation and Q&A. And then finally, I will end with some brief closing announcements. So Paul, if you're ready.
Yes, let us pray. Dear God, we come to you today thankful for all the good gifts and that you have given to us. We ask for your guidance in our lives. We pray that your love would live among us all. We thank you for the opportunity to gather virtually as we come to hear how we can better our lives. Bless the presenters as they share helpful information. We thank you for all those who are present and for Baptist Health for sharing with our community. We ask all these things in your son, Jesus' name, amen.
Amen. Thank you so much, Paul. So there are just a few housekeeping items that I would like to review before we get started with the presentation. So first, we are tracking tonight's attendance. So please be sure that your name is noted correctly on your profile. If it's not, you may change it by clicking the three buttons at the top right of your screen and then click rename. If not, simply type your name in the chat just so that we can track your attendance properly, okay? Secondly, my director, Ms. Lynn Sherman, will be monitoring the chat during the presentation. So please feel free to type in your questions there and they will be addressed during the Q&A segment. So without further ado, I would like to introduce our two speakers for the evening. First, we have Ms. Kayla Jones. Ms. Jones is a speech pathologist with 12 years of experience, and 10 of those years caring specifically for people with dementia and their families. She has worked in various settings, including long-term care, memory care, and now in an outpatient setting with Baptist Age Well. She is particularly passionate about promoting functional independence and quality of life for those living with dementia and their care partners. Next, we have Ms. Lori Watkins. Ms. Watkins has been a speech pathologist for 30 years, working in a variety of settings, including acute care, owning her own private practice, and in inpatient rehabilitation. Lori is happy to be a part of Baptist Age Well and enjoys getting to know each patient and their family. So ladies, if you want to go ahead on and prepare to share your screen. I'm going to stop sharing mine. But while they are preparing, I wanted to mention again to those of you who might have just joined us to please be sure that you ensure that your name is properly noted in the profile, and if in your profile, and if not, simply click those three buttons at the top of your picture, click rename, and you'll be able to change it there. If not, just simply type your name in the chat and we will be able to track your attendance that way. So ladies, you can take it away.
Thank you for having us. So tonight we're talking about cognition and dementia. Our focus will be on what exactly is cognition, normal versus abnormal aging, dementia and Alzheimer's disease, diagnosis and treatment options, and the brain healthy lifestyle. So we'll start by talking about some of the processes involved in cognition. Very often when people think about cognition, they think about memory. Memory is a big part of cognition, but it's only one part. So what is cognition? Put simply, it's all the brain-based skills that we use to carry out everything we do, whether it's something simple, like standing up from your chair, or something more complex, like managing your bills and your medication.
So we're going to go through and talk about each of these different processes in a little bit more detail, just so that everybody has an understanding of what they are. And as we go through, I want you to kind of be thinking ahead about what this might look like for a person with dementia who's having impairments with these different processes. So memory. Memory simply is the process of taking information in from the world around us, being able to process that information, store it, and then retrieve that information for later use. There are different types of memory: long-term memory, short-term memory. There can be an impairment in one system of memory and not an impairment in another system. So this is why you might see somebody who can tell you all about their childhood or their third grade teacher, but they have trouble trying to recall a phone number. Concentration and attention. This is being able to complete a task without getting distracted. You have to focus on certain information and then selectively ignore other information. So a way to think about this is I'm cooking dinner in the kitchen while also either ignoring or answering questions from my 6-year-old son running around. Orientation, this is your understanding of time, place, person, situation. So knowing who you are, where you are, what you're doing, and then just general information like knowing the day of the week, the month of the year. Language. So we have expressive language. This is, think about the output of information. So this is your ability to express your wants and needs and put your thoughts into words. Receptive information, this is your input of information. So this is being able to understand information, whether somebody is speaking to you or whether you're reading. Judgment. So this is your ability to make appropriate decisions, like knowing that it's not safe to give your credit card information out over the phone to a stranger, or knowing that you, let's say, need to take your walker with you if you're going out of the home so that you don't risk having a fall.
Reasoning and problem solving is thinking about something in a logical way. For instance, the amount of time that it would take you to drive across Jacksonville to make a 9 o'clock appointment in morning traffic. Sequencing. So this is doing things in logical order. For instance, making a grilled cheese sandwich. You know that you have to heat up the frying pan and you need to put butter on the bread and put before you put the bread in the frying pan. Visual spatial. This isn't poor eyesight or needing glasses. This is the way your brain interprets what you see, like depth perception or interpreting the space between objects. This is seeing that you have to step up into the shower or over the ledge, or you might be sitting down and eating and you're perceiving that your drink is a certain space away from you and knocking it over. So figurative language and humor, being able to interpret humor or metaphors or abstract information without being so literal. For instance, you might be talking to a friend and say, "Get out of here." You don't want them to literally stand up and leave the room. So hunger and thirst signals are our ability to perceive being hungry or thirsty, interpreting the sensation of being full after having a big meal, or feeling hungry when you haven't had anything to eat. These are all cognitive processes. And then insight. So insight into deficits. So that's the ability to step back and see yourself clearly, being able to identify changes in your thinking or memory. So sometimes this is a conversation that we have with families, since there are times that there are obvious signs of dementia and the patient is in denial or they're not aware of the fact that they're forgetting things.
So it can look like denial, but it's not necessarily denial. It's that they just aren't, they don't see the changes that have happened. It's difficult for them to perceive those changes.
Okay. So cognition and normal aging. So our brains do age just as our bodies do, but age-related changes typically don't prevent someone from functioning in their normal day-to-day routines. It may take longer to process information, so it might take a little bit more time for you to balance your checkbook or organize your medications. And it may take more effort to commit information to memory. You might need to hear instructions more than once, or ask for things in writing so that you have that visual cue to look back on. You might hesitate or be more cautious. You may see someone, but you just cannot remember their name. It might take a little bit longer to think of a word or remember the name of that actor that you watched in a movie last night. You may also be needing to be reminded of things that have happened.
Okay, so on the screen, these are the top 4 memory complaints. So this information was from a presentation given by Dr. Gary Small. He's a director of the UCLA Longevity Center. They've seen a lot of patients over the years, and through that period of time, they've come up with their top 4 memory complaints that they see in their patients. So number 1, names and faces. I think we can probably all relate to this. These can start happening as, in your 40s. So names and faces, 85% of older people say they can recognize a face, but have trouble coming up with the name. Forgetting where you put things. So not sure if anybody here has ever experienced trying to put something in a safe place, and then you find it 2 days later after you've been looking for it. Forgetting a plan. So like when you decide you're going to get up and go to the kitchen, and then you get to the kitchen and you cannot remember why you went in there in the first place. And then number 4 is the tip of the tongue phenomenon. So this is where you know what you want to say, you can see it, it's right on the tip of your tongue, but you just can't get the word out. So these things are considered to be a normal part of aging, but they are very frustrating. Because of these normal changes, it really becomes increasingly important that as a person ages, they develop systems to compensate for some of the changes that happen, to allow for increased independence. So these compensations might be more reliant on using a planner or a calendar, writing things down. Let's say you're a person who has trouble with names and faces, learning to use some kind of association strategy. So you meet a person named Betty and you picture them doing the funky chicken with Betty White. God rest her soul. Let's say you're a person, you put things down and you forget where you put them. So try to come up with a singular place in your house where you put important things like your wallet, your keys. I had a patient very recently, she was in my office, and her biggest complaint was she could never find her keys. So, it's not rocket science. The solution was, all right, get a little hook, put it beside your door, and train yourself to put your keys on there. And a couple of weeks later, she came back and just could not believe the amount of free time that she had, now that she wasn't looking for her keys all the time. If you're a person who forgets why you walk into a room, and that's starting to happen more and more. A strategy might be learning to train yourself to pay more attention to those times. And if the plan is that you're getting up from the living room to go get a pair of socks, try to visualize yourself doing that. So take a second, draw attention, picture yourself putting the socks on, or even better, picture yourself putting a pair of socks on your head. Sometimes the more silly, vivid image you can give yourself, the better it is in terms of a strategy for trying to remember.
So while many cognitive processes are affected by age, the good news is others are barely touched. Typical aging does not mean that all of your cognitive skills will decline. Some are preserved, and some can even get better with time, like emotional processing, resiliency, and the ability to recover from negative situations, as well as the ability to use a rich vocabulary and say what you mean. So what is dementia? Dementia is a collection of symptoms linked to problems with cognition that impact a person's ability to function in everyday life. Dementia is not a normal part of aging, although age is a risk factor. It's a combination of signs and symptoms and their severity, enough to interfere with your day-to-day functioning, that determines whether a person meets the criteria for dementia. There are many diseases and conditions that can cause dementia. The signs, symptoms, and progression will vary depending on the underlying disease process. Causes are numerous, including Alzheimer's disease, vascular disorders such as high blood pressure, metabolic or endocrine imbalances such as diabetes, a buildup of fluid in the brain, reaction to medications, infection, chronic alcoholism, poisoning, or toxicity. So dementia is basically an umbrella term. The umbrella term for loss of memory and other thinking abilities severe enough to interfere with your daily life. So under the dementia umbrella, you'll see different types of dementias: Alzheimer's, Lewy bodies, vascular dementia, mixed dementia. Sometimes dementia might be caused by more than one type of cause.
Okay, so like we saw on the previous screen, so umbrella is this dementia term. I'm sorry, dementia is an umbrella term, and the most common cause of dementia is Alzheimer's disease. So again, just to, I think it's becoming more and more understood by the general population, but I think for a very long time, there was a misperception that that all dementia was Alzheimer's, or that those were synonymous. You could use them interchangeably, where in fact, Alzheimer's is just one type of dementia. Again, it is the most prevalent type, so it makes up 60 to 80% of cases. It's a neurodegenerative disease, and it's characterized by plaques and tangles in your brain. It typically starts in one area of the brain, generally the hippocampus. This is the part of the brain that is really key in the formation of new memories, which is why a lot of times in people with Alzheimer's, that's the first big sign that we see are changes in memory. So starts in one part of the brain and then does, spread over time. And as you can see from the bottom of the screen, it's characterized again by these plaques and tangles, as well as just general brain atrophy. So for the next couple of slides, this is from the Alzheimer's Association. These are 10 early warning signs and symptoms of Alzheimer's dementia. We're not going to go through each of these. We are going to provide a handout at the end of our presentation, and this information is on there. So I want you just to think back to those cognitive processes that we talked about. And, again, Alzheimer's, dementia, you're going to see changes in those different processes. So problems with problem solving, problems with the visual spatial skills, disorientation to time and place, poor judgment. So you might not realize that it's not a good idea to give your credit card information over the phone. Significant changes in mood and personality, and this, not just being a grumpy old man, but more withdrawn or agitation. Yeah.
So if it looks like a duck and quacks like a duck, then it's a duck, right? Well, not necessarily. There are other conditions that can cause similar cognitive issues. So we call these the 3 Ds. So dementia, depression, and delirium. And while they can often occur at the same time, symptoms could specifically be related to possibly depression or delirium. So someone with depression can impact how they feel, how they think, eat, sleep, act. And like in dementia, a person with depression might be confused or forgetful or slower to respond. So with delirium, a person with delirium might be disoriented or restless, irritable, have hallucinations even. So delirium is more of a sudden onset that's usually caused from something like a toxicity or even like a urinary tract infection can cause a sudden onset of confusion. So other things that can impact cognition are hearing loss. If you cannot hear what someone's telling you, you're not going to be able to remember it accurately. Poor nutrition, stress, anxiety, sleep deprivation, errors with your medication, alcohol use, illness or infection, low thyroid levels, or metabolic disorders.
So there are different conditions that can look like dementia, and then different factors that impact cognition. So what's important to note is a lot of these things that are on this slide, these are things that can be modified, they can be treated. Depression, for example, if a person's memory and processing issues are related to depression, that's important to know because that's something that can be modified. So I think two really big things that we want to kind of point out here is, one, there are normal changes that happen in the brain. We see a lot of patients that come in to see us for testing, and they're very worried, they're very concerned about some changes that they're seeing. And they want to know, is this normal? Is this not normal? So it's important to determine that, but it's equally as important, if you are having some of these changes in your cognition, some signs and symptoms, it's really critical to look into it and figure out what's going on. Because if it is not related to something like what you see on the screen, it could be due to a neurodegenerative disorder like Alzheimer's, but you don't really know until you go in for testing. And so that's kind of where we're going to transition to talking a little bit about what that might look like.
So obviously you're going to present to your physician your concerns, and several tests are often used to determine the cause of the person's symptoms and show whether or not a person has dementia or pinpoint the best way to move forward. So they'll take a medical history and clinical interview. So it's really nice to have a family member present because sometimes people do have poor insight and the physical impairment versus the cognitive impairment. Mm-hmm. So they're going to look at physical and neurological exam, probably do lab work to look for any deficiencies or your thyroid levels. They may possibly do imaging tests like a CAT scan or an MRI. And then there's cognitive testing, which is what we do.
So there's, if your physician determines that you need testing, so we'll talk a little bit about what that looks like. And this is really true, or this is important for people who are, they are noticing concerns. Or even if they just want to get a baseline to figure out kind of where they're functioning. So, people ask, why do we do cognitive testing? And one way to kind of look at this, if a person walks into the office and they have a physical impairment, so that's something you can see, right? They have trouble walking, they might use a walker or a cane or be in a wheelchair. So we can see those physical deficits. You can't always see that with cognition. A person can walk into a physician's office and have a really lovely conversation, and their receptive language is great. They can understand everything you're talking about and asking, but then that person might go home and have trouble remembering to take their medications every night. So again, think back to all those different areas of cognition, not just memory. So cognitive testing really helps to kind of decipher whether or not there is a concern. So it helps determine what you're seeing. Is this typical aging? What cognitive changes are present, and how do they impact the person's daily life? Because again, to meet the criteria for dementia, dementia is where these processes do impact your ability to function in daily life. Testing can help to establish a person's specific baseline. So this is, even if a person isn't necessarily having overt concerns or problems, we have that that baseline information that day going forward of when you're well and you're healthy, this is how you function, versus 1, 2, 3 years down the road. If you come back in for testing, then we have your normal to compare yourself to. It also, as therapists, it helps. We're really big into compensatory strategies. So how can we compensate for the problems that you're currently having, so that you can continue to be as independent as possible? If a person doesn't need to rely on a family member to remember dates and times, they're able to use some kind of system like a planner or a calendar, then, we want to help train them how to do that. So cognitive testing measures different things. Just again, think about those different cognitive processes that we talked about. So testing is going to look at those different processes. So we're not going to go into a lot of information about this, but we did just kind of want to flash the names up on the screen. There are some, in the US, there are some FDA approved medications. This is something that you would talk to your physician about to get a prescription for. So it's really beyond our scope as therapists and beyond the scope of this presentation to go into this a lot, but just kind of for a general understanding, there are 2 classes of medications, acetylcholinesterase inhibitors and Mnda antagonists. And you'll see the 3 there on the left and the 1 on the right. So the acetylcholinesterase inhibitors, those would generally be started in a milder stage of dementia. And then as a person progresses, they might add on the Mnda or memantine medication in conjunction with the other medications. On the bottom, Aduhelm, this is I'm sure that you guys have probably heard about this medication. It was just FDA approved in June of 2021. It's the first novel medication to come on the market since 2003. And it's the first drug that was designed to try to target the pathophysiology that we see in Alzheimer's disease. The drugs up top, these are just symptom reduction medications. So you take them with, that they're designed to try to reduce symptoms. They're not going to change they're not going to change your brain. If you stop taking the medications, they're not going to have a lasting effect. Aduhelm on the bottom, there's a lot of controversy around this medication, so we're not going to spend a lot of time talking about it. There's quite a process to be approved for this drug, to determine if you're a candidate, and it's also in the news right now for to determine whether Medicare will actually cover this drug. So
okay, so what about lifestyle? So right now, this is a huge area of study in medicine. How dementia is understood, diagnosed, and treated is beginning to shift. So more and more research suggests that while there are risk factors that can increase your risk for dementia, there may also be ways that you can prevent it. There are proactive steps that we can take throughout our lives to support brain health and function. It's easier to protect a healthy brain than it is to try to repair a brain that has endured years of poor nutrition or stress or a sedentary lifestyle. And this is true for any system of your body. So small changes can make a big impact, and we're going to talk about some of those changes coming up. What's interesting about Alzheimer's, for example, is that we know that the disease process, those plaques and tangles that Kayla was talking about, generally begin in the brain decades before symptoms ever manifest. So before even a person is diagnosed with dementia. So additionally, research has shown that some people have those brain markers of Alzheimer's disease, those plaques and tangles, but they have no symptoms of cognitive decline or what we would classify as dementia. So understanding the why to all of this is still ongoing, but it does appear that the more we incorporate a brain healthy lifestyle, the more resilient our brains are, even in the face of a disease process such as Alzheimer's. So there are risk factors that we can change and some that we can't change. So the things that we can't change are our age, our family history or our genetics, past medical problems that we've had, or a head trauma. But things that you can change are your dietary patterns, physical exercise, cognitive engagement, making yourself learn a new language, or just challenging yourself to think about or try different things. Sleep patterns, hobbies, musical activities, social engagement, stress reduction, single and multi-nutrients, like making sure you don't have a deficiency in a certain vitamin, cardiovascular risks, like maintaining your blood pressure, your cholesterol, limiting alcohol, and managing your hearing loss.
So, so we're going to talk a little more specifically about what we would consider to be a brain healthy lifestyle. So, like Lori said, there's so much research that's really focused right now on what we can do to try to reduce our risk from ever getting something like Alzheimer's disease or dementia. So it just so happens that the same things that we can do to reduce our risk for dementia, these are the same things that we can do to improve the quality of life for somebody living with dementia. So this is true. So if you're a person in your 30s or your 40s and you have no concern, but want to help your brain function optimally or reduce your risk of dementia in the future, or if you're a care partner for a person with dementia, and you're trying to help them to mitigate or reduce symptoms, these are the things that we're about to discuss. These are things that could be helpful with both classes of those people. So there's no one size fits all approach, but in general, these are the 5 things that we'll go into a little bit more depth on. So physical exercise. There's more research on the impact of physical exercise than there is on anything else that you're going to see. We know that it's the single most important thing that you can do to enhance the function and resiliency of your brain. Conversely, physical inactivity has been calculated to be the most significant risk factor for cognitive decline and dementia. I don't know if you've heard the phrase that sitting is the new smoking, but that's the reason for that phrase. So the research really points to the magic number of 150 minutes. So at the very minimum, it's recommended to try to get 150 minutes of moderate exercise a week. So getting your blood pumping for 150 minutes. And this can be broken down to, 30 minutes a day, 5 days a week, or 15 minutes in the morning, 10 in the evening, really broken down whatever way it's going to work. We have a lot of patients, we spend a lot of time with our patients talking about brain healthy lifestyle. And we see a lot of people that have physical impairments and they're not able to get up and do this, but there's truly some type of exercise for everybody, whether it's looking on YouTube at videos for chair yoga, or getting one of the respirator bikes and getting your blood pumping that way. So just because you can't get to a gym or run a marathon, there are things that you can do. And again, all of these things that we're talking about, these are things that are beneficial for people trying to promote brain health and also trying to help their loved one who is already maybe has a diagnosis. Number 2, so nutrition. Surprise, eating healthy is good for you. I'm sure most of you have heard of the Mediterranean diet. That diet really has the most, there's a lot of research around that diet in particular. And within the past few years, there's a newer diet called the Mind diet. This is kind of a mesh between the Mediterranean and the DASH diet. So Mind diet stands for the Mediterranean Dash Intervention for Neurodegenerative Delay. So this diet, the Mind diet, really kind of lays out 10 healthy brain foods and then 5 foods that you should try to avoid. And there's a lot of information out there on the internet, there are books. So I really encourage you guys to look more into that. There was a study done with a big group of folks with the MIND diet, and there were kind of 3 tiers of people following this diet. So the top tier followed it the most, and then the middle tier, maybe moderately, and then the lower tier, the lower 1/3 who didn't really follow the diet. The top third of the participants who followed this diet most closely had a 53% reduction in their risk of Alzheimer's disease, whereas the middle 1/3 had still a 35% reduction. So I think that's really good news that you don't have to completely follow this to a T to get some really good benefits. Thirdly, cognitive stimulation. So we're trying to, this is something that you achieve really over the course of your life, that continued learning, continued brain stimulation. We have people who are, they're retired and they just want to kick back in their recliner and watch TV, and then they come in and they say, my brain's not working like it used to. Well, that makes total sense. You really have to continue to your brain likes to be challenged. Your brain likes variety. Your brain needs to continue learning. That continues to build those neural networks, strengthens that reserve in your brain, so that again, even if you have a process like Alzheimer's disease or just age in general, it really helps it's a neuroprotective. Number 4, sleep, rest, relaxation. So sleep research indicates it's the most important thing you can do to reset your brain and your body. This is when your body heals itself, even grows and strengthens memory. And the rest and relaxation part, this could be, there's so much research on the benefits of things like meditation and yoga. Reducing stress. Yes, for sure. Don't stress out. Lastly, socialization and purpose. So what's your reason for getting out of bed every day? What's your reason for doing this? If you don't have a purpose, then you need to find one. This can be something different for everybody. It can be church. It can be your dog. It can be your grandkids. It can be that you like making pound cakes for your whole neighborhood. It can be anything. Research tells us that older people who are more socially engaged tend to have a higher level of cognitive function. And it doesn't mean that you have to have hundreds of friends. It means that you need to feel connected. Oops. All right. So we're going to shift a little bit. And I really like this slide. So as you can see, dementia, it doesn't rob someone of their dignity. It's our reaction to them that does. So just for the last part, we're going to talk a little bit about stigma, the stigma around dementia and how it impacts people with dementia and the people that are caring for them. So stigma refers to the negative labels that we use to identify a person with dementia. It could be limitations that we put on people that have a diagnosis. It can be myths, misperceptions, a lack of understanding of the disease. And I can't stress this enough. It has, the way that we look at dementia, it has a huge impact on the people who have a diagnosis and the people that are caring for them. So it's the stigma very often that prevents somebody from coming into the office for testing or to ask questions in the first place. So it really limits the chances that a person can have on some of those early interventions that we know are available. It causes people to hide their diagnosis. It's very isolating. It proliferates misinformation. It limits access to caregivers and limits their social support network, which is something that they are really going to need if they are a person caring for someone with dementia. And it just robs people of time, this precious time that they have to live their lives and make plans and make decisions and make modifications that are going to make it easier for themselves and for their family members. We also wanted to talk a little bit about dementia in minority groups. So according to the research, Black and Hispanic adults are impacted at a much higher rate than white adults. For adults age 50 and older, Black adults are 2 to 3 times more likely to be diagnosed with dementia. Latino adults are 1.5 times more likely. So the reasons for this appear to be multifactorial. In an article from the American Heart Association, one of the physicians was quoted saying, "We don't know exactly why. More and more evidence is pointing to a mix of factors that are health related, such as disparities in diabetes, heart disease, but there are also social and economic factors." So again, thinking back to those modifiable versus non-modifiable risk factors, being able to manage those, again, managing blood pressure. According to the research, Black adults tend to have more severe high blood pressure issues that are developed at an earlier age, which could result in things like vascular dementia. All right, so lastly, this is our last slide. So going forward, what can you do? What can you do? So hopefully everybody's going to go away and live a brain healthy lifestyle. But truly, educate yourself. Listening to a presentation like this, don't be afraid to talk to your doctor. That is critical. If we really could drive one thing home, it is talk to your doctor. If you are concerned, ask questions. Age is the #1 risk factor for people with dementia. Anybody over the age of 65 should have this conversation with your doctor, whether you feel like you're having concerns or not, because the earlier you can start trying to mitigate some of those modifiable risk factors, the better. Be open to joining clinical trials. We live in the big city of Jacksonville. Those things are options in a place like this. Any drug that's ever been on the market, any change that's ever been made started with a clinical trial. So it's just something to look into. Help create communities that promote healthier living. And this starts with you and your own family and your own neighborhood, the people in your church, the people in your social group. And then lastly, be an advocate for equal access to the resources that we talked about, those resources that we know help to reduce risk. That's it. That's all we have for now.
All right, thank you so much, Kayla and Lori, for such an informative presentation. Now we've reached the Q&A segment. And so before I turn it over to Lynn, I just wanted to remind everyone to please be sure that you are correctly accounted for by making sure that your name in your profile is correct. And if not, simply type it in the chat. It's no problem. So Lynn.
Hi, ladies. Thank you, Kayla and Lori, for all of that good information. I learned a lot. I know I certainly did. And you had several questions here. So I'm going to ask you the first question that came from our audience. And that is, if the person in question refuses to be tested, what options are there for an alternative way for the person to be assessed or evaluated for a diagnosis?
That's a really good question. And we see that a lot, in our office, we work off something called the Global Deterioration Scale, and it's this 7-point scale. It goes for #1 with no cognitive impairment all the way to a 7. And this is someone with severe dementia, like you might see in a memory care unit. Once a person gets to about stage 4 or 5, denial and that resistance, that agitation can be very, very prevalent. It's always really helpful if we're able to get a person into an office like this and do, a really formal assessment. But it's not always necessary. Even with AgeWell, for example, we have an occupational therapist who goes into the home, and, a lot can be learned just from kind of an informal observation, seeing how a person is responding in their environment when they're trying to do those activities of daily living. A lot of great information can just be obtained from
questioning
clinical
or-
interview with the
Mhm.
family and what they're seeing. So again, the diagnosis of dementia is truly, does this person have dementia? Well, do they have a are their cognitive processes impacting their ability to function in daily life? And it's, if they see a physician, the physician is likely going to start with, again, the labs, the blood work to make sure there's not some kind of underlying mitigating symptoms. And I know I've had quite a few people come into the office and they really are very resistant to testing, and it kind of depends on the level of the person. But I know for us, doing the best we can to try to build rapport, letting the person know that we're not there. This is not a test of your intelligence. It really is about promoting your independence and health as much as possible.
And we look for strengths as well as weaknesses. We look for things that we can build on, or areas that can help you be successful. We try to talk to people about, this is keeping you as independent as you possibly can be, with even if there are some deficits or some weaknesses. We try to teach those compensations so that people can stay as independent as possible for as long as possible.
Thank you both. Thanks for those answers to that question. We have another question. You talked a little bit about cognitive stimulation. Can you give some specific examples or more examples than what you shared earlier? Someone is interested in how to make sure that they are providing themselves with more cognitive stimulation.
Yeah, that's such a good question. And this answer is really going to depend on, so are we talking about a person of normal functioning who's trying to maintain? Those activities are going to look very different than a person with moderate to severe dementia. It's equally as important in both groups of people. So let's just quickly, we'll kind of take a person with maybe moderate to severe, moderate dementia. That person is at home. They still need to be stimulated, have a sense of purpose. Even if they can't cook and prepare a meal anymore, they can probably peel potatoes or, dry the dishes, or possibly help set the table with some assistance. So providing that kind of stimulation, finding the things the person can do. So even if a person can't sit down and read a book anymore, they may enjoy just that visual stimulation of flipping through a magazine, reminiscing, so engaging them in a conversation about their long-term memory, things from their childhood that they remember. For a person with relatively normal cognitive function, it's for me, I get cognitive stimulation from coming to work every day and putting together presentations and working with colleagues. So thinking about how can you kind of create that if you're retired. So, reading, writing, there are some really great workbook, brain stimulation workbooks. You want to focus on learning something new, learning a new language. Jacksonville has these Ollie, I don't know if you're familiar with that, but Jacksonville has this, adult learning programs. Learn to play the UNF, yeah, learn to play the guitar. Find something that you like and learn something new. It doesn't have to be sitting down and doing workbooks. It's just having that ongoing sense of discovery and learning and challenging your brain.
And there's computer games that you can do that challenge you, that even become more difficult as you progress. Or if you can't, complete a task, they drop it down a little bit so that you can be successful. Kayla was talking about UNF has an Ollie program. It's for people over the age of 55, and it's adult classes. They're not long, like a semester, but it might be on making a grapevine wreath. It might be on history. There's so many things in Jacksonville that if we can get out of our house and do, but also things that you can do at home. And they say too, if there's something that's more challenging, like for me, it would be math. I'm more language based. Those are things that are good for you to focus on too, just to challenge yourself.
I also would like to say that we're very lucky to live where we do. Jacksonville has such a plethora of resources through the Council of Aging and the senior centers. I don't know about you, Lori, but I have so many patients come in. They're like, I don't want to go to a senior center with all those old people. And I'm like, it's not old people. It's people like you who are looking to engage. And I mean, they play mahjong and tai chi, and I want to go to one of the senior centers. There's so many things. Herbology. Yeah. Is that, I don't even know. I can't even pronounce it.
Those sound like really good ideas, and I'm sure you've given all of us something to think about when it comes to cognitive stimulation. So we have another question here, and this has to do with how we infuse our community with the understanding of Alzheimer's. And this question, this person asks, in your professional opinion, is there a reason why we should not integrate the best available evidence about brain health and cognitive decline risk factors into existing health communications that promote health and chronic condition management for people across the lifespan? Not just wait until they're having a challenge, but shouldn't we make this part of our common conversation?
Absolutely. Absolutely.
Yeah, that's my soapbox, actually. It's infuriating that we don't, like Lori said, this is, I truly think and I pray that we are having a shift now. But even doing a presentation like this, it can start with the patient going to their doctor and saying, hey, I know there's more that I can do. I know that this isn't normal. I know there are things that we can do. What can we do to help prevent this? It should be more a part of our standard of care. It's infuriating that things like diet or like hearing aids, there's such a huge risk, there's such a huge correlation between hearing loss and dementia. People with hearing loss, especially profound hearing loss, are at twice the risk for dementia. So the fact that we can't just help people pay for things like hearing aids is infuriating. But yeah, there's we agree. There is no reason why this should not be part of the normal.
That is certainly a piece of it, information that I didn't know, and I'm sure that others on the phone didn't know, because we probably all know someone in our life who has a hearing problem, at least an older person that has a hearing problem, and so that's certainly good information to have. We have another question as it relates to dementia and COVID. Our participant, our guests, want to know, have you seen a significant impact of COVID on dementia progression? Have you seen COVID as a barrier on early intervention? Can you tell us?
Yes. Do you want to take this?
Go ahead.
Sorry, I'm doing all the talking. So I actually spent a lot of time in long-term care facilities during the start and kind of the middle and through COVID, and that I hate to keep saying that's multifactorial, but what we're seeing with the progression of dementia and COVID, I certainly believe that yes, it had a huge factor on progressing dementia in a lot of people. Now, whether that was the disease process itself or certainly things like isolation had a huge impact on, because again, you're not getting that cognitive stimulation, you're not getting that socialization, and that's huge for people. I know that there's a lot of research about like long COVID and the changes in cognition. I'm not going to speak to something I don't know about. I know there is research out there on that. But in terms of just kind of the socialization and isolation part, and then certainly if, for a long period of time, a person, they're told not to go out of their homes and they don't know how to work Zooms to do online visits with their physician. A person goes 2 years without checking in with a doctor. I can only imagine that's going to have some impact on early detection, and or family members not being able to see mom, 80-year-old mom for a year, and then you go see her. And I mean, this is true for my own family. You see your loved one for the first time in a year and a half, and it's evident that there have been some changes.
And I think too, the COVID isolation has caused a level of depression with many of the people that we've treated. We've had people that are fairly high functioning coming in and questioning do I have dementia? Because they've
Mhm.
been isolated. They haven't had stimulation for so long. And they have maybe some normal aging related memory or, cognitive deficits, but they're nowhere near dementia. And so being alone and not having the stimulation or being able to do things in their normal daily lives has had an impact, definitely.
Thank you. Thank you for that, Kayla and Lori. I have two very quick questions, and if we can get two quick answers, because we want to get folks out of here on time. But there are only two, so I'm going to ask you all those questions anyway. One person says, my husband has FTD, and I don't know what FTD stands for. I'm hoping that you all do. And it is so common for younger people. How can I be an advocate and share our story? So what is FTD, first of all?
Yeah, it's frontotemporal dementia. So that is a form of dementia where the frontal and temporal regions of your brain are affected first. There's several different kinds. It can manifest itself very differently.
Okay.
If that is, I don't know when, but it progresses quickly, and it is something that tends to affect people at the onset is for people that are a lot younger. So it is hard because I know this is one of those, not a lot of people know about it. So, if that's you and your loved one, I know that most different types of dementia, they have kind of their own organization that you may be able to go online and get involved with an organization that's specific for that and learn about some different advocacy resources.
Okay, thank you for that. Now, you spoke about early in age, and our last question is, how early in age can a person begin to show signs of dementia?
Can we do that?
Quickly.
Okay. So there is such thing as early onset dementia, and that's something that you can start seeing changes in your 30s and 40s. Generally for people in terms of, because age is the biggest risk factor for dementia, after the age of 65, every 5 years, your risk significantly increases. So it truly depends, but it's probably, it's something you could start to see as, early as your 60s, 70s. And again, that disease process is happening in your brain a lot earlier than that.
A lot earlier than by the time you begin to see.
Yeah.
So thank you. Thank you, ladies, so very much. This has been extremely informative, and we really appreciate the time you took to answer the questions for our audience and to share this information with all of us, because we've all learned a lot, I believe. So we are now.
Thank you for the opportunity.
Yes, and also, go ahead, Lane. Go ahead, Lane. I'm sorry.
Just going to turn this back over to Zavanya so that she can make any announcements that our participants would need to know about. Zavanya.
Thank you so much, Lynn, for facilitating that Q&A. Thank you again, Lori and Kayla. That was amazing. Such an informative presentation. For those who were not able to get their answers tonight, no worries. We will make sure that Kayla and Lori get your questions, and I will make sure to reach out to you to make sure that you get those answers, okay? So just literally 3 announcements that I have to share. Let's see here. So as the ladies did mention today, there will be an electronic handout that will be emailed to all registrants that cover the information that was shared today, the general information that was shared today. We ask that you please participate in a survey that we've actually put in the chat tonight. That will also be emailed as well. We ask that you please participate in that survey and share your feedback on tonight's session, and some suggestions, or what we did great tonight, which I hope is a lot, and what you would like to see in the future. And then next, join us next month. We're going to be right back here on February the 22nd I've included the flyer because I want to give you a heads up of what you'll see. I will be emailing that as well for you to pre-register early. We had about 55 people in tonight's session, which was amazing for our first session. So thank you all so much for joining us. We hope that you will join us next month as we talk about heart health. Dr. Mona Shaw will be joining us. So thank you all again. That ends our session tonight, and we hope to see you again next month. Thank you all.